Good afternoon, everyone. My name is Viri De Ruiz. I'm the Associate Director of Business Development at Abarca Health. I'm joined here by a panel of industry experts in specialty pharmacy. I'm really delighted to be the moderator for this important conversation today. So today we're going to dive into the challenges and innovations in specialty pharmacy space. So with me, I have Sheila Arquette. She's the President and CEO of the National Association of Specialty Pharmacy. And then I have Mike Baldzicki, the Chief Commercial Officer at Polaris Specialty Pharmacy. I have Nguyen from CHRISTUS Health, and Sabnani, President and CEO of Alivia Health Specialty Pharmacy. So we're really excited to dive into the very important topics of specialty pharmacy. As you guys know, specialty pharmacy accounts for over 50% of the pharmacy spend, yet it's only about 1 to 2% of specialty utilization. So it's a really important topic that we're going to dive into today. All right, so to start, for our audience, guys, I want to level set, and if you guys could each briefly introduce yourself and just share your background and how you know specialty pharmacy today, that would be wonderful. So we can level set there. Mike, do you want to start?
Sure, Mike Baldzicki. I'm the Chief Commercial Officer for Polaris Specialty Pharmacy. I have a total of about 25 years. I call it full spectrum within the healthcare ecosystem. I've been with pharmaceutical and biotech to wholesale, GPO, startup specialty pharmacies, and infusion pharmacies to other healthcare services organizations.
Great, thank you. Sheila?
So I'm Sheila Arquette, and I'm the President and CEO of the National Association of Specialty Pharmacy. I'm a pharmacist by training, and I've been in this role at NASP for 7.5 years. And then prior to joining NASP, I was pharmacy director at a health plan that had its own PBM and also started its own specialty pharmacy during my tenure.
Great. Tina?
Hi, I'm Tina Nguyen, and I'm currently the pharmacy manager for CHRISTUS Health Plan. We are a integrated healthcare delivery system. We have our own specialty pharmacy. So like it or not, as a payer, I'm pretty much have to deal with paying for these drugs. So, and also ensuring that our members get access to the medication as well.
Great. My name is Sabnani. I'm the President and CEO of Alivia Health in Puerto Rico. We own specialty pharmacy, retail pharmacies, infusion pharmacies, and home delivery pharmacies. And as we speak, we're the biggest player in specialty for Puerto Rico with over 50% market share of all the specialty products. And I have 25 years of experience in pharmaceutical companies, pharmaceutical distribution, and as a pharmacy owner since 2016.
Great. Thank you, guys. So we're going to start and dive into industry trends and insights. So I'd like to hear from you guys. What are the most significant trends currently shaping the specialty pharmacy industry? And more importantly, what are some of the challenges and solutions that we can bring forward to these very important topics?
I'll take that first.
Yeah.
I think some of the rising strategic initiatives that we're seeing in specialty pharmacy evolve is really the next kind of digital therapeutics and technology. I think we're just at the cusp of what we're seeing happen in digital therapeutics and technology platforms, more streamlining what we're looking at for medical benefit, particularly with infusion type drugs, and more data and outcomes measurements based on what we're reviewing of that information. I always say, especially pharmacies really evolved over the last 10 years. It was pretty simple. A pharmacy benefit versus medical benefit, but I think it's 4 quadrants right now, looking at not only traditional pharmacy benefit oral therapies that continue to evolve, but that medical benefit is really creeping up just because of the pharmaceutical pipeline in the medical benefit infusion space. So there's 2 areas that I think are really going to affect not only cost but access to patients and how specialty pharmacy evolves into it. And that's the rare ultra orphan space and then the gene cell therapy. You really have to tackle this differently. And again, we're going to see this. I tell a lot of people it's going to hit us in the face because the pipeline is really growing rapidly. And we're seeing that in rare disease first it kind of launches, but as well the gene cell therapy market.
Can you share a little bit about what Polaris is doing to support health plans and employer groups in that space?
Yeah, I think one is partnerships. Really look at how we can really partner around these therapies. It's just not going to a typical payer and trying to get in-network contracts anymore. I think, again, if that's your strategy, you're going to be out of that network pretty quickly. I think innovation is the next step, is what are you doing to offer more value-based or outcomes-based agreements from a contractual standpoint, but really manage it and provide access to these patients more thoroughly. So again, technology enhancement, advancement, and implementation is going to be key. So we're taking huge strides to invest in our technology platform. So we just, again, the last year probably spent $4 or $5 million on our proprietary technology, hiring AI-type PhD folks to really look at that prior authorization process and impede that into our technology components to more effectively grab information, particularly, like I said, the medical benefit. These infusion-type drugs are going to escalate the cost for that employer group. And I think that's where employers are really trying to understand is that, that third-party administration, that self-insured market, because if you are following industry trends and what payers are forcing, is the ASO or the self-insured markets are growing rapidly, even faster than health plans.
Yeah.
So those employer groups are coming to the health plans or their brokers and screaming, saying, hey, medical benefit, do something, or I'm going to do something myself. And it's really trying to find a medium point of how to do that with traditional PBM management, or do you go to a third-party vendor that we're seeing these companies pop up everywhere now to trying to get more insights to the data, but more cost-effective solutions.
Yeah, that's right. And Ari, what are you seeing in Puerto Rico? Are you seeing the same challenges?
Similar challenges, seeing the rising cost of the specialty drugs, it's the margin erosion, it's continues every year. And now we have the genetics and gene therapy that, one dispense, it's, over $1 million, a couple of $1 million. And, as a specialty pharmacy, that it's complicated to manage, all the working capital you need to make sure you have those drugs available. Also, we see challenges in each of the payers. They have their own books, and you have a team of people that needs to make sure that they understand each of the payers and each of the PBMs and managed care organization rules and medical policies, because if not, the patient is going to be always behind and not being able to start treatment as fast as possible. And the expertise in knowing each of these different managed care organization requirements is one of the key challenges that we face. We're managing through a lot of training, constant training with our teams, and specialization, making sure that we have people specialized in PBM, medical benefit, as you mentioned, as we see more and more drugs coming in that area, and also in patient assistance programs. As these drugs get more and more expensive, we need to make sure that we really master all of the patient assistance programs available to give access to the patient to those and be able to start them in treatment. But we see similar trends. Yeah.
That's great. Sheila, are there any other challenges that you want to highlight or talk about today?
Sure. So I think there's, affordability continues to be a challenge for patients, right? And so that can limit access, that can impact adherence, but I think reimbursement too for our specialty pharmacy members is huge, right? And they're, continue to be asked to do more with less, right? When these margins continue to shrink and shrink, it's very hard to take care of patients. These therapies are becoming much more involved, right? Patients are becoming much more involved to manage. So that's definitely a pain point for my members. Also, network inclusion is also definitely an issue. My pharmacies want to take care of patients, but sometimes they're precluded, right, from doing so just based on, rules of network participation. So, those are two big, I think, definite pain points for my members.
And what are some of the solutions you're trying to deploy or that you've seen deployed in the industry?
So we're working, trying to advocate on behalf of specialty pharmacy. We started way back when I joined NASP, and it was, meeting with members of Congress and just even educating them about what is specialty pharmacy and why should they care, right? They didn't know, and that's what they said. Well, we don't know what this is, and why should we even care about it? We have a laundry list of concerns, right, that we deal with on a day-to-day basis. So it was educating those members of Congress and their staff, developing pharmacy champions, and now trying to move forward legislation and regulation that will protect specialty pharmacies and help with reimbursement, ensuring that it's reasonable and relevant and fair, and that vertical integration isn't being used to exclude folks, right? Like Ari, from network participation. Our pharmacies want to compete, right? They want to take care of patients. They're not afraid of having their performance measured, but they need to have the opportunity.
Yeah, I think also a challenge for us is how we show, PBM managed care organizations the value we add. How as a specialty pharmacy, you're managing a patient, you're managing disease state, you're explaining this patient what's going to happen with them, not just using the medication that you're dispensing, but with their new disease and their new diagnosis. A lot of them, the diagnoses we manage are very big, life-changing diagnosis, and the emotional toll on these patients is huge. And there's a lot of things that the pharmacy, as a specialty pharmacy, does to manage this patient, to support this patient through a clinical program to achieve adherence, compliance, management of side effects that are really not paid. There are services that we do as specialty pharmacies, and we are accredited and we're required to do, but still some challenges on how we show the value that we're adding and in coordination with the healthcare professional to make sure that that patient is getting the best out of their treatment.
Tina, are you seeing some of the same challenges?
I want to add to what Mike has said earlier. As a payer perspective, how do we really show the value, like the overall endpoint of that? Are they improving in their health? I mean, all this specialty, which is, first of all, I don't see it as being specialty no more when there's so many. It started out with being specialty because there's special reason for these drugs, right? So now to me, it's almost like common. It's not specialty no more. But how do we really, how do we the endpoint? How do I keep my population healthy with these drugs? And the value base, I think, will be more important. Value-based outcomes will be more important.
Is your organization doing anything from a value-based perspective to kind of quantify that?
Just mainly engaging in that more analytics to show, investing in more kind of care management program to follow the patient to see if they are really improving with these specialty medications.
That's great.
I'll just add on to that. I mean, I think one of the points you alluded to is this margin erosion. Not only reimbursement fee schedules that we're seeing across the board, even particularly this year, a lot of independent pharmacies had a huge influx of challenges with the varying fee schedules that we've seen change. And especially pharmacy, just in pharmacy benefit, you're lucky to make 1, maybe 2, 3% gross profit margin off a drug. And when you're looking at, I call it the patient journey mapping, that we have to customize how we manage these patients and how we get them to adherent, comply with the medication, report on that. There's a influx of how we juggle that. And I think we're in an influx between who's going to own what and do what, because right now I think this space has become so multifaceted. Everyone owns a piece of specialty pharmacy. You have chain drugstores owning this piece of pie. You have health systems owning specialty pharmacy to a certain extent, maybe even full spectrum. Even becoming PBM. So again, it's really becoming such a stir of a mess of chaos, not only for pharma, how to deal with that, but how do you set your reimbursement fee schedules based on those multifaceted entities now owning a piece of that, and who's going to own what to manage that patient, and then how do you report? Because technology can only go so far on interoperability with all these platforms to measure, grab, and obtain certain outcomes that we need to report to the payer. So again, I think we're in an influx in our specialty pharmacy segments right now to say, who are the players now and how do we work with pharma? How do we work with payers? And what we're seeing now is not just margin erosion, but the programs that we rely on, patient assistance, copay assistance, pharma is now depleting those funds because again, the pipeline's so robust, the medications are so expensive, they're now catching on that, we can't afford all this money. So they're pulling back on those funds now. So that makes it even a second level of complication for us as we service these members.
So that's a great segue into my next question. So as we look up to the future in the next 5 years, what do you think specialty pharmacy looks like, right? Is there going to be a shift in models? Are the coupon programs going to go away? Are we going to, continue to support patients? Because these drugs are already very expensive, right? So affordability, I think, will be a big issue going forward.
Yeah, I think what we're going to see, and I use hemophilia as a great example. I just come from that space with immune globulins and hemophilia. I mean, in the late 90s, you may have had 4 to 6 products. The average cost of a hemophilia patient may be cost of the health plan at an employer of $150,000 based on how they dosed. Well, now in the market, you have 24 products with gene cell therapy in the mix with that. And the average cost of this patient based on the type of drugs that are better and how they're managing their disease is better, and how they're dosing is prophylactically, the average cost for a hemophilia patient is over $600,000. So again, we're getting better with medication, how we deliver that medication, it's subcutaneous, intramuscular, so these patients are more compliant, they're better. And now there's digital tools to, accept that patient journey mapping, how we customize and manage these patients. So again, it's taking certain elements of our model and incorporating digital therapeutics technology to oversight certain care components of how we grab that information or how we manage that. That's the sensitive part of that. But again, what we're going to see is, I think still mismanagement of things, just because we have a challenge of interoperability with all these platforms. You got all these wearable devices that can track things. You got, SaaS type companies. We got direct provider engagement tools and websites. So again, it's, over encompassing the system of who to work with and how to grab the appropriate information, because what we're going to still see is huge costs in these medications because the pipeline. But again, medications are better. So what does that do to the patient? It confuses them. And for the pharmacies, how do we change our model? And I think that's the biggest challenge, is how do we do that moving forward?
Right.
Yeah, in those lines, I believe that the model is going to continue to transition in more patient focus and making sure that we're not just dispensing a drug, but that we're managing a patient hand to hand with the physician's office, having more communication with the nurses and the physicians. What I see with this growth in, medical benefit drugs, which are, IV, the majority of them, even though we're not administering them, the patient is calling back to us with any issues they have with, their disease or the product. And that's then becoming more of a patient management role and unique, specific programs to manage different patient types, and having a lot more interaction, as I mentioned, with the healthcare professionals on how to manage this patient, how to report back to them something that we capture through a call of a patient, and how we should manage the patient on behalf of that physician's office in a better way. I think that's going to be part of what we'll be doing, and there will need to be a model to get compensated for that too, because it's the only way specialty pharmacy will be able to continue adding, nurses and pharmacists and staff that can really support the patient in that way.
So more of a pay for performance model in the future.
Yes, for sure. And the capture of health outcomes. How we continue investing in technology that can help us capture more data and health outcomes to prove the value we're adding, to the mix.
Yeah, and I think in Puerto Rico, there's more of a challenge with interoperability, right? So what do you think about that? And do you think that in the next 5 years that region will get there too?
I don't see that change happening. In oncology, let's say, it's all solo offices. Physicians are not together. They don't have, big groups. They're not owned by hospitals. They're like very understaffed. They may have one nurse and maybe one office administrator. And that's why they delegate all the, pre-authorization process to the pharmacy. And they're looking for that partner that can really master the pre-authorization process, knows exactly what the managed care organization or PBM is going to require, and that can request from them exactly what is needed, not to have them doing more than is needed, and that can speed up the process with the patient. The majority of physicians are administering at their offices, but we then provide the product because they don't do buy and bill. And I don't see that model changing because it requires, capital, requires billing capabilities, and until there are not bigger groups that can really finance and put the money in order to have those capabilities, I don't see the change happening soon, at least in Puerto Rico.
What are some of the major changes that you foresee or envision over the next 5 years, specifically in Puerto Rico?
Yeah, one thing that I'm starting to see is that managed care organizations are interested in interfacing with specialty pharmacies. We started already a project with 2 of the biggest managed care organizations for a pre-authorization process. Why we need to enter, information in our systems and in their systems, why we cannot just have interface between my system and your system to make sure that everything goes directly without manual intervention or by doing double entries, and we're already working fast on getting those things done. What I'm presenting to the managed care presidents and management is that it's not just margin of the product. How you can lower your cost of operations, making sure that the specialty pharmacy is an arm of your company. It's like an extension of the managed care organization. can also, be profitable because
Right.
you're reducing, costs, you're speeding up the process, you're just, making sure that you integrate it with your biggest providers. And that's something we're seeing. Majority of these investments and technology changes are coming by 2025 early Q1, but we started already to do the development. We see that coming.
That's great.
Yeah, I think that's an interesting point of the differences between Puerto Rico and US. I mean, I've been in Puerto Rico and launched some components around that, and it's an entirely different market than the US. In the US, the provider groups are large, right? So they're coming together, and I think, from that point, the direct provider engagement, not only the technology behind that, what they're doing, but I think logistically in the distribution space, we're going to see more innovation around GPO models with large provider groups. So again, we're seeing large rheumatology, dermatology, immunology groups really come together. You're talking 630, say, derm docs with 130 locations form their own GPO, and looking for select or exclusive specialty pharmacy partners to fill in the gaps and really creating these unique partnerships, because again, what they're looking for is that logistic care measurement model that they can't do. So I think we're going to see logistically in that component of the GPO evolve, direct provider tools and distribution around these type of high cost therapies to help the provider groups really manage these patients a little bit better. But it's going to change the game of how we look at that. Besides, I think certain Blues plans are being innovative as well on buy and bill. So we're part of a program with Blue Shield that allows certain select drugs list that says, hey, you have an option. You can buy and bill this, or you can give it to the network and let it, white bag or let them handle it. It's your option though. So they're being a la carte with certain drugs, so let the provider groups decide based on, do they get poor reimbursement? Is it complicated to do that in the office, and let the specialty pharmacy do it? So again, we're starting to see innovative models around these high cost therapies.
And that's on the medical side, right?
Correct.
But I think the time is now, to Tari's point, is for the pharmacists to stand up, right? And to demonstrate that they are the medication expert, right? You serve as, the specialty pharmacy serves as an extension of the provider office. We have to get away from doing a lot of those tests that nobody else wants to do. A lot of that administrative, that's not why they went to pharmacy school, right? They are very good at care coordination and definitely can step into that role, but they have to be seen as a vital member of the healthcare delivery team. And I don't think, I'm a pharmacist, I don't think that's ever been the feeling, right? And it's such an untapped resource. And I think we're at an inflection point here for specialty, and we have to, right? We have to stand up, we have to prove our value, and then we want to make sure we cultivate those relationships. So when there is a question in these oncology offices, they're calling you, right? Not just to fill out the paperwork, but geez, we have a patient and there's this interaction, or they're having this side effect, can you help? Right, and I think that's where this has to move in the next 5 years.
Another thing I see that's going to happen with specialty pharmacy is that we will become like patient navigators. I see more and more specialty pharmacy doing the coordination for the patient with infusion center, with the physician's office if they're going to administer their lab testing, even transportation. We do that, for some of the patients because they don't have the tools to do it. Or they don't have trained or, people at their families that can support them in that process, and they get lost. They depend on someone that can help them navigate. When you get a cancer, diagnosis and you feel that your life is going to end, you get confused. You don't know what's going to happen, and they're looking for support. And I see our staff, working on all those coordinations that the patient need. And I said, this is going to be part of the future. It's like, who's taking ownership of that patient and helping the patient through the entire, continuum of the treatment and answering questions, as you said. We go to physicians' offices, oncology offices to train patients in groups, like 10, 12 of them. They can be from our pharmacy or not, around what's cancer, what you should do, with nutrition, with exercise, what you should eat or don't eat, how you manage your emotions, through such a difficult diagnosis. And physicians are opening the space to us because they don't have the time to do it themselves. And they want, trained nurses to come and do it. Obviously, we don't charge for that. It's part of the service that we want to provide to partner with healthcare professionals and for patients to see how we can, add value to them. But little by little, if this gets more and more of a requirement, then it needs to be a compensation model for the specialty pharmacy to do those things.
What kind of success or clinical improvements and outcomes have you seen with that model? It sounds like you're very high touch, personalized care with your pharmacy.
Well, we see it's a lot better adherence and compliance. You know, we're having quarterly business reviews with all of the managed care organizations and PBMs that we, you know, have contracts with, and we show them, you know, how these interactions are impacting the results of adherence and compliance with their members. And also we do, you know, patient surveys per managed care organization to show them, you know, these are your member responses. This is what they're saying about our service, good or bad, and what we're doing, you know, regarding the feedback. But the most we see adherence and compliance. You know, it's managing the side effects of some of these products is difficult. And the patient, if they don't know, they don't understand, and they don't know what to expect, which I see that's helping. Because then they know, okay, this is happening to me, but it's normal. They explain it to me that this was something possible to happen. And physicians are giving us the feedback, you know, around, you know, how the patients are, you know, getting better at maintaining their medication.
That's great. There's more adherence then with that type of approach. Do you think that with artificial intelligence that there will be an opportunity in the future to automate some of the things that are kind of administrative burdens for your...
For sure, I think, and not just, you know, in adherence, but, you know, you will be able to have so much data together of different patients that you will be able to predict, you know, with new patients, how they may behave and what things you should attack first, you know, because all that data together will compare with these new people coming, and you will have a better map of predicting, you know, how you have to manage that patient in order to stay compliant.
All right, we're going to move on to healthcare provider collaboration. So our next question is, how can specialty pharmacies better collaborate with healthcare providers to ensure optimal patient care? Who wants to take that one?
Yeah, one thing we're doing, I think I mentioned it to you before, it's a key account model. The key account model, it's, you know, we have a group of 4 people which are dedicated to 10 accounts, and you know, those physicians and their staff just talk to those 4 people at our pharmacy. And it's really helping, you know, both our company and the physicians' offices, because now we know how they work, how they want things to be done. You know, if they want a weekly reconciliation of patients, how they want, you know, the delivery to be done, if there's a day or 2 before administration, because they're always talking with the same group of people. We've seen that this model of having a more controllable, you know, a group of people working with the physician's office is really helping. And it's been very welcome by physicians, because they feel it's giving them the opportunity to speed up patients and create that relationship that is needed, you know, for the pharmacy to know what's happening inside of that office. Also, we are, you know, we're having calls to discuss cases with our pharmacists and physicians, depending on when is there an opportunity for like bile rounding or for waste, you know, savings. You know, we're having those calls with them, and it's very, very well, you know, welcomed by them, because they see us then as part of their treatment group. And I see it as a good result, at least for our company, having those touch with the physician.
Yeah, I agree. I mean, we have almost a similar model at Polaris. So, you know, most pharmacies, I think, adopted what we call the advocacy model, where they have patient advocates working with maybe a pharma program that's very customized to work with those patients. We have a concierge level model. It's pharmacist based. So it's all pharmacists, and they basically integrate with that provider group. So they work hand in hand with those providers, but more importantly, we take our technology proprietary tool that embeds into the EMR and pulls the information right off the provider group's EMR from prior authorization, et cetera. So we're not reaching out and bugging the provider all the time. It's grabbing it appropriately. And it's also customized based on the pharma program we're partnered with. So those concierge folks that are designated to that provider group of, say, immunologists, they're working with those provider groups, making sure the patient's being managed, making sure the PA or medical necessities built in there. So the less burdensome that labor is for them, and we can take some of that with those concierge and the technology. It streamlines everything. But, to that point, I think, again, we're in this influx of, watching ourselves in specialty pharmacy not becoming managed service organizations. It's a sensitive role just because pharmacists, we got to get reimbursed somehow. And if they're going to deplete continuously the fee schedules, we can't continue to provide all these levels of services on 1% to 2% gross profit margin off drug. And that's, I think, the old model. So we got to evolve it and really create, fee structures and fee schedules or different codes that, the services we're providing, especially with our pharmacists, are provided in regards to, a revenue stream for us to keep our lights on, in a sense.
Right.
And that's still the battle right now that we're in an influx of.
Tina, what do you think?
I think so. Some of our pharmacists would do academic detailing or really with the biosimilar to improve the uptake. We really want to, educate our provider to kind of to improve adoption of the use of biosimilars. So having pharmacists really, because being the integrated healthcare system, we have pharmacists already at the clinic. So even having touch point with our own members and our own providers, I think having that multidisciplinary really helps with.
Are your patients picking up prescriptions at a retail pharmacy or through your?
It could be through our specialty or our PBM. We have different methods for our specialty medications.
What do you think of Mike's comments? You're from the payer perspective where we have to shift the model and, pay pharmacies more. Obviously, from the payer perspective, I'm sure you're hearing from your employer groups that the specialty trend is high. How can we lower it? So,
yes.
What do you think about that?
I agree. We have to kind of change the way the modeling to really have to take a step outside and to see if really using technology and different platforms to really provide our providers, really giving the real-time data to our providers so that they can take care of the patients.
Yeah, absolutely. All right. Next question here. What are some of the best practices for effective communication and coordination between specialty pharmacies and other healthcare professionals? And I want to take it a step further too. What about members? I'm just thinking about, these patients that are in chronic conditions are getting calls from their nurses, from their pharmacies for multiple intervention points. So what are you guys seeing in the industry, or what is your organization doing to kind of coordinate all of that so it's not a massive confusion and it's clear to the patient, what?
The way we do it, it's for self-administered products in which the patient is not going to go to an infusion center or to the physician's office to be administered. We manage all the clinical program with the patient. We make sure that they receive calls from nurses before the dispensing is done. The physicians know that it's because it's self-administered, we're going to take care of that portion. We always communicate that to them because you don't want to get them confused. That's exactly why we do it this way. For products that are going to be administered at the physician's office, the agreement we have with physicians is that they are going to manage the clinical program, and the patient is going to call to us if they have a question or they have a side effect and they cannot, or for any reason they didn't call the physician's office, they can use the pharmacy. We get over 3,000 to 4,000 calls per month just from patients that are administered at physician's offices, but they want nursing consultation or pharmacist consultation for the drug they're being administered. And that way we try not to bombard the patient with different calls and differentiate self-administered from drugs that are going to be administered at the physician's office or infusion.
Okay.
I think though, patients now are pretty sophisticated, right? And so they're consumers and they're individuals. So they want, I think, the approach to be personalized, right? So I think it's key to talking to them. How do you want to be communicated with? It's the same with physician offices, right? We have so many different technology platforms and options, but some patients, want you to text them. Some people want you to call them. Some people want you to email them. Some people might actually want to talk on the phone, right? Or do a Zoom call. Same thing with doctor's offices, right? You can fax. Now there's two-way HIPAA compliant messaging back and forth. But I think it's that personalization. Again, I think specialty pharmacy has to kind of step back and say, how do I show the value that I can deliver? And it's not just in, cutting the medication dispense, the cost of the medication. Right, it is through compliance and adherence, but it's through all of these other things, through even helping, a doctor or a patient select a biosimilar based on somebody's formulary, understanding how that whole process works. So I think, again, it's got to be a personalized approach. In order for us to, get somebody like Tina to want to pay for something that we say that we're delivering value, right?
Right.
Yeah, first we have to kind of show, and then I think it's, and you work with the providers who may be in shared risk arrangements and are going to be penalized if the patient isn't adherent. Well, you need your pharmacist. So, and then, once, you kind of get them dependent on you, then you start saying, well, now somebody's got to pay us for this, right?
Yes.
Look, we can do it and we can help you, but to Mike's point, right, we need to be reimbursed accordingly.
Right. So we can have those personalized care. Absolutely.
Yeah, and to Sheila's point, I think it's a great point to illustrate that recent data shows that, even with technology and its continued rise of use, that now even the elderly population are more adapted to using technology, so that rich text and enrichment messaging and links and so forth to getting onto a portal or an app to monitor even telehealth. So before, like 5-8 years ago, the elderly population were just not there. So as we continue to, evolve in technology and the use of it, I think we're really adaptive to those type of, hits to the consumer, saying, how do you want to be managed? Do you like rich text and enablement? Do you want to go on a portal? Do you want to, everything's, for even me personally, you go to doctors, dentists, dermatologists, everything's, here's an app, click on it, build your profile, and everything's built through there. And it's pretty easy to use anymore. And besides, I think we're going to continue to see the involvement of EMR, EHR integration. There's a lot of advancements in AI technology around that, of how various platforms embed themselves into the EMR to grab information to make it less labor intensive for the provider.
Yeah, absolutely. You keep going into these perfect segues to the topic. So yes, the next topic is technology and innovation. So what technology advancements are having the greatest impact on specialty pharmacy operations today?
Yeah, well, we invested recently over $2 million. As you mentioned, all of this is very expensive. It's, patient portals, physician portals, to make sure they don't have to call us to check on the status of the medication, that they know in the process that's been approved or not, it's going to be coordinated for delivery, and for physicians to post all the information they need there in case of justification, and stop the fax back and forth. I know that's still being used, but it's very inefficient, and there's no certainty that it was received or not. And all those tools that are, innovation for them to see in a platform, it's really helping us significantly. Also, systems to capture health outcome data. We don't have all the health outcome data because we don't have all the information about, if the patient went to a hospital or they went to a physician's office, but we can really capture a lot of health outcome data that if you don't have a system for that, there's no way to present, to make sure that in those meetings we have quarterly with payers, how we're adding value, because how you create that opportunity of maybe be paid for something that you're doing, it's showing the value you add, and from their side of the payer, looking at the different providers and say, where I have better results, where's the outcome I want to see, which of these providers is really adding the value I want. They have the data because they can see everything that's being administered to the patient or the services that the patient received. I'm not sure they're looking at it in the detail to see which providers are really doing the extra mile and should be then compensated by it.
Right.
Yeah, I think we're taking an approach of really, and it may be different, but we're really working with pharma partners, the biopharma companies. Again, you go where the pipeline's being launched, right? So either they're launching a new product first of kind or coming into a competitive market. What we're trying to get ahead of it, if they're launching in phase 2 on, or they're coming in to launch a product, is really getting ahead of the curve with them of how do we launch that product with them? How do we work with and embed, the tools and resources into the technology, into the EMR ahead of time, so we're pulling the right information on that specific drug that may have a robust medical policy against it, a double-step edit, a prior authorization, medical necessity need. So it's more streamlined and integrated to our technology, but grabbing the right information, but also managing that patient appropriately. So again, we're really trying to get a step in front of the pharma companies coming out with these products, especially in rare disease, because it has to be so customized where the clinical intervention needs to be, right? Is there a pathway? Because I think, what we're going to also see is with the robust pipeline in rare disease, ultra orphan, and eventually gene cell therapy, like we see in oncology, we have oncology pathways. There's going to be more and more pathways created. We're seeing them really start into these large integrated health systems within neurology and immunology, that we're going to see pathways develop because you have to. I mean, hemophilia is a great example. You had 4 products, 6 products in the 90s. You got 24 in the market right now with another 26 in the pipeline. You have to do something, especially with gene cell therapy creating a $3-4 million price tag. Who can afford that? So again, with the financial models that have to be made and creating appropriate clinical intervention with appropriate pathways on product selection, that's where pharmacists come in. That's where specialty pharmacy impedes itself and how we do that appropriately.
And I think with like more personalized medicine, right, as we go to that approach, I think it'd be awesome if we could start to use AI to be able to provide information back to physicians about this actual patient, right? So now we've looked at everything that's happened to them, and we know that, this is how they're going to act, right? Because people, despite our best efforts, right, they go home and do what they do. And so if you could say to them, okay, well, you're gonna, you're looking at selecting this really complicated regimen. We know from everything they've done the last 5 years, it's probably not gonna work, right? Let's not do that. Let's try this, right? And again, I think an opportunity for the pharmacist to step in and to be able to guide that physician, right? And not to be wasting money on treatments that somebody isn't either going to take or isn't going to be successful with. I think we have to get out of that. When I was a payer for a long time, we have to get out of that like population-based health approach, right? Because we're moving away from that. Or this step therapy, try this. We're going to know this sex. Now what do we do, right? So what do we make? How do we make the best use of these resources that are finite? Right. So I think, AI and the technology that's coming is going to be really instrumental. If we can just harness all of the information that's in all these different places and pull it all together, right? And you kind of have like a little, like a little picture or summary of you when you go to the doctor. Okay, this is what I know about him. And it can include a lot of different things, not just the prescription history, but their social history. If they have, financial issues, a lot of patients don't want to talk about that. They're embarrassed, right? But the specialty pharmacy knows, you can share it in a discreet way. Maybe we're not going to pick something super expensive that they can't afford to fill. So I think this could really be a tailored approach that could be pretty exciting. And there's a role for specialty pharmacy there.
Yeah, absolutely. I think interoperability will be huge with connecting all of that together.
Well, especially looking at the holistic approach of the patient. I mean, I was in part of some of these AI technology opportunities in the last 3 years with companies. And we took, one of the most expensive drugs, IVIG, immunoglobulins, and took a diagnosis called CIDP. We work with a large Blues plan in Florida, and we said, this diagnosis with these many patients, and we see the rise of various entities like ambulatory infusion centers. How many live within a 50-mile radius or less of NAIC versus being treated in the home for infusion? And we started managing, besides just IVIG, other medications that they may need infused on. So again, site of care and patient demographics, we did a heat map and found varying differences of where these patients live, but also holistically, some may have lived in, a sick-person trailer park. That's probably not the best home infusion, but they would live 5 miles up the street from the ambulatory infusion center. Let's move them there for appropriate infusion. So again, I think we're going to see more of these tools, AI specifically, embedded into our daily technology platforms to say, how do we manage them better? Let's get the holistic approach and see what's really demographically, geographically going to be meaningful besides just looking at the meds and cost.
Right. Had you not known, right, they were in a 6-person trailer, right? The big push was get everybody into their home, right? That's the most cost-effective site of service, but maybe not, right? Based on that individual patient.
Well, especially with the rise of ambulatory infusion centers, and I've said this to you before, Sheila. I mean, I think, again, with the robust pipeline in gene cell therapy, right now they're at the 10 centers of excellence, or 5, whatever the pharmaceutical manufacturer chooses. But, we're working with some of these gene cell therapies where we choose based on, again, treating more larger populations. I mean, again, rare disease was 20,000 or less. We're seeing populations hit 100,000 in these rare disease pipelines. So again, how do you reach those populations? It's through creating centers of excellence or therapeutical centers of excellence in these AICs with physicians that are experts in this, and how do you reach those populations appropriately?
Yeah, absolutely. I think site of care will be a huge thing. And to your point, we need to make sure it's personalized, so we're not just putting everybody in a bucket. Absolutely. So now we're going to go on to questions from our audience. First question is on the topic of rising costs. Given the increasing cost of specialty medications, what strategies have you seen that are most effective in balancing patient access with financial sustainability? Who wants to answer that one?
I think we mentioned about the biosimilar.
Yeah.
Hopefully, that we've been waiting for the biosimilar to now they arrived, but yet we haven't really seen how it's going to play out. So I'm hoping to educate our providers now that we've moved more of the biosimilar on the formulary. Maybe perhaps we're gonna hopefully get our patients and our providers to start prescribing those medications.
Yeah. The other thing we're doing, as I think I mentioned, was the expertise. How you can have a group of experts on reimbursement that they, and there's systems, that we acquire that help you also identify any patient assistance program available for that drug and for that patient. It's like a matching system. The opportunity there is to make sure, you have that expertise to offer it to the patient, to explain to them, what it's available. And also we offer payment plans for patients that cannot afford their medication and there's no patient assistance programs, or if the assistance programs are exhausted, which happens during the year.
Mm-hmm.
Sometimes after 6-9 months in the drug, you exhaust the money to cover your copayment. Then we offer also, payment plans to patients.
That's wonderful.
Yeah.
Well, and pharmacy is, a price taker, right? They're not a price maker. So I think where the opportunity here is through adherence. It's also in product selection, right? Helping with, biosimilars or therapeutic alternatives. There are some generics, not a lot for specialty drugs. Connecting patients with copay assistance. And then if they are dropping off, on therapy, they're not adherent, getting back in touch with the prescriber. Hey, we have an issue, right? Raise the flag. So I think it is, making sure that the investment that was made by the payer in that therapy, whatever the cost, right? It doesn't have to be very, very expensive, but to make sure that we get the benefit out of it. And if we're not, that we pivot, right, before we get too far down the road and then something happens to the patient, they end up in an emergency room or, they need a hospitalization, something like that. So I think, but I think there's a tremendous role there for specialty pharmacy.
For sure.
Absolutely.
Yeah, I think to your point, exhaust our resources. Really hire the personnel that know how to work the ins and outs of these programs, because there's so much of them and still more to come. We're seeing a large amount of new alternative financial models come, especially for the gene cell therapy markets. Watch New York and Connecticut banks come out with different financial models to exhaust in the gene cell therapy market. We're going to see those come. Some have already launched out there to afford these type of medications. But to that point, there's great organizations out there, new companies coming out to understand what's available for these patients, to make sure that we don't impede access, but affordability is going to be key. And again, there's so many different ins and outs of looking at all these programs. Hire the talent, because it matters. Even us, for even certain therapies like IVIG, we offer our own financial assistance program.
That's great. All right, the second question is on value-based care. With the shift towards value-based care models, how do you think specialty pharmacies can effectively measure and demonstrate the value they bring to patient outcomes? And we talked about it a little bit, but maybe we can recap a little bit.
Yeah, it's in our case, we're investing in technology that can really measure health outcomes more than adherence and compliance. And it's starting, we just got it, and we're just, getting all the data in the system from the patient and doing clinical program with the patient, just to continue asking those questions that are needed to have an outcome to share with managed care. I think the investment in those kind of systems is critical, and having those quarterly meetings with the payer to show, how you're managing those lives, for them to see, okay, this is the value these people it's adding. It's like in the biosimilar adoption,
Right.
we have meetings with all of the managed care organizations to know which product they prefer. And we're reaching out to the physician's office to let them know, because we know which, managed care organizations they're managing, and we want them to send the prescription to us already with a biosimilar that is accepted by the plan, because then you're just pushing a problem to the managed care organization or PBM. How as pharmacies, then we can also, manage that adoption. Yeah.
Right, so value-based agreements, right, are designed or structured around getting from the drug what we expect to get from the drug. The way that happens is the patient takes it, right? So, and you know, obviously the doctor has to do their part, the health plan, but the pharmacy can really, you know, be very helpful in keeping the patient adherent to that medication. We even have, you know, new technology where there's like little robots and things that go into people's homes. Because even, you know, like Harry, you know, the more you can counsel somebody so much, but again, they still go home,
Yeah.
they forget, they drop it, they throw it out, you know, they do crazy things.
Mhm.
So there's these little, you know, there's robots in the home that can kind of, you know, help them stay compliant and adherent, talk to them, or you put, you know, a syringe, you know, into a counter and it knows, right? Just kind of keep people on track. And so I think that's probably the biggest value,
Yeah.
right? Is making sure that people understand, you know, their disease, how they're being treated, what they're being treated with, and how important it is to take this medication.
Yeah, I agree. I think technology and data are two terms that is really, you know, we're just at the cusp of really seeing value-based or outcome-based care agreements. And I think the issue is, you know, really how to get clean data. And what's interesting in the last, you know, 3 to 4 years, particularly the last 2, I would say is, you know, I think biopharma companies coming into the launch of rare disease are really changing their mindset of who to partner on their network arrangements. So they're really getting away from, I call it the big boys, and going to independents and maybe choosing 1 or 2, maybe 3, but that's it, because they want clean data. They have to. If you really understand not only rare disease, but gene cell therapy of how they come up with these products, it's limited data. So we need more data, and we need the data to be clean, because as soon as you have more networks and pharmacies and other people scrubbing and touching it, it becomes unclean, and you don't really get a good value of that information. So again, I think technology is really going to push us there. I mean, I attended in St. Louis a very large healthcare technology summit, and I was blown away of what is coming in regards to what's going to be made available for not only consumer, but for pharmacies in general to manage more value-based care agreements put in place.
That's awesome. That's wonderful.
And those agreements are also opportunity for us because, as you mentioned, pharma is willing to pay and enhance services to specialty pharmacies.
That is taken off.
Yes, and that's helping us a lot too, because you know you're providing some services which are not your normal day-to-day service. You know, adding calls, you know, adding clinical programs that pharma wants to make sure you provide to the patient precisely to have the adherence, compliance, and outcomes that are needed, and you know, pharmacies are getting paid through those agreements a little bit more to be able to provide the services.
Great. All right. The next question is on patient engagement. Patient engagement is crucial in managing complex therapies. What innovative approaches have you seen or used to enhance patient adherence and engagement in specialty pharmacy? I think we touched on this again, but just recapping a little.
Yeah, I think again, it's, you know, to what we've all said is, you know, that customized model that it goes with each therapy, and even specific to the drug of how we customize that patient journey mapping and what is appropriate when interventions needed based on clinical or drug appropriateness to making sure they're adherent, taking the meds, and how do we apply the technology and the services behind that, either live or through rich text enablement to ensure that we're getting a response. Some patients, I mean, we have hemophilia patients don't even pick up the phone ever.
Oh, wow.
So how do you get a hold of them? So, you know, we got to be innovative enough where we work with their employer group or, you know, what have you to, you know, intervene appropriately to get the information that we need so they're being adherent to their medication.
But and I don't know about you, but it was my experience, hemophilia patients are some of the most adherent and like
They are.
skilled patients.
That's why I love them, like, don't touch my stuff.
And they know exactly what they're doing, right? They know how much factor they need. They know they're having a bleed.
Yeah.
They start a tourniquet. I mean, it's amazing. People can't manage the cold like these people
Yeah.
manage a major bleeding disorder. But I think the key again is personalization, right? So you're not going to bother those people who don't want to be bothered with you, right? They're doing fine as long as they know I'm here if you need me.
Right.
And then you concentrate the resources on those patients that do need a little extra care, right? Or some hand holding. And again, it's just how do you want us to contact you, right? Because
Yeah.
we do have all of these tools now at our fingertips. I think one of the very few benefits of COVID is people became much more accepting of, you know, digital engagement,
That's
right?
true.
So let's play on that, right? And so, you know, if you want us to text you, we can do that, right? We have a HIPAA compliant platform that lets us do that. We can, you know, we can call you, we can do a Zoom call, we can, you know, email you, whatever it is that you want. And I think the key is getting people engaged in their own healthcare, right? And so if you give them options, it's a much different conversation than this is what we're going to do, right? And so now they don't have to have any accountability because you're driving the train.
Right, exactly. That's
We
great.
even explored how to provide patient incentives. So, you know,
And that's changing. I think I'm sure you're hearing it from the payer side. I mean, I've been longstanding with working in the TPA self-insured markets and brokers, and it's amazing over the last 3-4 years what these TPAs, self-insured employer groups, are really trying to do to, incentivize their employers to make the right decision. And you got some large TPAs that cover 600, 700,000 lives, and they're putting together some innovative programs with their brokers and their select partners of PBMs to implement better adherence and outcomes based on, say, hey, you're pregnant, we partner with these 4 hospitals, you have a choice. So if you choose one of these, we're going to put money back in your paycheck. If not, that's fine, but it's going to cost you this. So, educating consumer with the self-insured markets is a great thing right now.
Yeah, that is key. Well, that's a wrap. I want to thank everyone for joining us today. Hope this conversation was valuable for you today, and really thank all of our panelists here today for taking the time out of their day to share their knowledge on this very important topic.
No, thank you.
Thank you.
Thank you.